I'm Dr. Stanley Lam, a musculoskeletal sports and pain physician from Hong Kong. Today, I'm going to demonstrate how we can use Sonic ultrasound system to make a demonstration how we can utilize that for especially the dynamic ultrasound to make a diagnosis of musculoskeletal and neuromuscular pain conditions. I would like to use shoulder as an example here. We start with the shoulder examination here. And in fact, you can see when I'm scanning the subscapularis, we see a cortical irregularity over here. And this is subscapularis, and that's the long-handed bicep. And this is the cortical irregularity and cortical break of that subscapularis. So I'm going to use this trying to move Robin as to see how this cortical irregularity is corresponding to whatever trauma he has had before. And I'm going to pivot the medial side of the probe towards the coracoid process here. And the coracoid process is on the left side of the screen right now. When I see the coracoid process over the left side, and then I'm having the subscapularis in the middle, and then with the break of the cortical break right over there, then I'm going to do this coracoid impingement, and then we're not seeing snapping of the subscapularis to the coracoid process, which is good. But at the same time, I like to pivot the lateral side of the probe towards the acromion process. And this is the coracoid-acromion ligament. And with seeing the coracoid-acromion ligament, then I'm going to do the external rotation and internal rotation. And you can see an anterior superior instability of Robin's shoulder here. You can see that each time when I'm doing this internal rotation, you can see this, the humeral head right now is underneath the coracoid-acromion ligament. And each time when you're doing this external rotation and internal rotation, you can see the humeral head is hitting the coracoid-acromion ligament. And what's really or having friction between these coracoid-acromion ligaments, then I take a look at that, and I'm scanning to this humerus. Then you see all the cortical break, and at the same time, if I turn the probe a little bit more, and we see the cortical irregularities. And I like to see whether that is having a click. Now I'm in the short axis to the coracoid-acromion ligament. And each time when I'm doing this, you can see soft tissues are having some break with the coracoid-acromion ligament. So the coracoid-acromion ligament, in fact, if the patient is having anterior superior instability, is in fact having a snapping of the soft tissues towards the coracoid-acromion ligament, which is a lot of time patients are presenting with cracking or snapping of the shoulder underneath, and when you're doing this internal rotation and external rotation. So that's one way of doing it. Okay, then you can see some of the fluid accumulation right here. Okay, so this time I'm trying to show another very common problem is the impingement. So when you ask the patient to do an impingement, remember you're following the range of movement of the glenohumeral joint. So the movement right now is along this fascial plane. You demonstrate to the patient, then you're asking the patient to do that themselves, and then the probe is just following the movement. So you can see, Robin, can you move a little bit more than that? And you feel a little bit of a clicking sound underneath, right? So this is basically in the initial phase of this abduction. You can see that there is bulging of that supraspinatus or the rotator cuff tendon sheath, and the subdeltoid bursa has been pushed up by this supraspinatus tendon. So, and then he can feel that, I can feel that. There is some friction, increasing friction when the humeral head keeps moving up. So this is one way of showing the earlier phase of the impingement. In fact, in this part, from the base of the acromion to the top of the humeral head, should be 1 centimeter and should keep that 1 centimeter all along that abduction. So you can see the distance between the bottom of the acromion to the top of the humerus, in fact, is less than 1 centimeter. And when he's doing this abduction, that 1 centimeter has been decreasing, and it's almost none, and then up. So he still can do that, but he has a lot of this so-called cortical break over the attachment, the articular surface of the supraspinatus right there. So this is the articular surface irregularity. That's one of the impingement signs. But clinically, when you're seeing patients, usually they're going to have problem when they reach out to do this. So Robin, I'd like you to do this, reach out and then back. So try to do this, reach out and back. You keep doing it, then I just follow you. And back. And back. So you try to pay attention to any jumping or any snapping, which he still does not have. But do you have any pain when you reach out like that? You have some pain, right? Especially if you're starting to feel pain because your acromion is having a lot of friction between the humeral head and the acromion. So right now, right, you have this is stiffness feeling and also pain at the same time. So that's when the patient presenting with a lot of discomfort. So you demonstrate to the patient that you're going to do this and then back, and then you're trying to see the friction. And then in fact, you can see Robin when he's doing this, almost to this extreme, and he's doing this.
Ultrasound-wise, we would like to see other structures like nerves. Okay, we are now at the posterior shoulder. We can do our posterior impingement test. But at this time, I would like to go underneath, and you can see this is the teres minor muscle in the middle of the screen. When we see the teres minor, and then the next muscle you're going to see is going underneath the humerus right here. This is the teres major and go to the front. So in between the teres minor and the teres major, and you're also seeing the glenoid right here, and you can see the short head of tricep right here, and all these are forming the quadrangular space where the axillary nerve and artery is coming out. And axillary nerve, when you see the axillary nerve and the posterior circumflex artery is coming out. So when I turn on the color, and then you're going to see right here. So this is the posterior circumflex artery and the axillary nerve right here. Okay. So we see the artery right here. So this is the axillary nerve and the posterior circumflex artery. And between the teres minor, teres major, and teres major here, teres minor here, lateral short head of triceps, and the long head of triceps. So if I turn the probe 90 degrees this time, you're going to see over the humerus, you can see that this is teres minor, and this is the short head of triceps. And then you have the teres major is going to the front, and the axillary nerve and posterior circumflex artery is going to get to from that quadrangular space. Underneath the quadrangular space, you have another triangle, which is called the triangular space. That we have the radial nerve going together with the profundus brachii. The radial nerve going together with profundus brachii. You can see that this is the radial nerve leaving the brachial plexus here and to surface in the spiral groove right here together with profundus brachii, and it's going to leave the lateral edge of the tricep, and after leaving the lateral head of the tricep right here, it's going to go between the brachialis and cochrobrachialis, and to go to the cubital fossa. And at the cubital fossa, it's going to split to the deep branch and also the superficial branch. The deep branch will go between the two heads of the supinator right here. So another application of this ultrasound is we are going to see dynamic movement of the nerves in the upper limb, and then we can see one nerve which we frequently and widely assessed. Okay, this is the median nerve. The median nerve in the middle. Okay, this is another application of this ultrasound when we're trying to see the median nerve. So remember the median nerve, you can scan between the flexor digitorum superficialis and profundus, and then to see that it surface at the quadrangular pronatus. And then to be right at the distal radial ulnar joint and to surface, and it will go underneath the flexor retinaculum here. And then this is the flexor retinaculum. This is the flexor retinaculum. And then with all these flexor digitorum tendons and with the flexor pollicis longus tendon. And outside the flexor retinaculum, you also have the flexor carpa radialis. And on the ulnar side, you have the ulnar artery and ulnar nerve. Okay. So traditionally, you're going to ask the patient to do this palm up position, and then you assess the patient like that. But clinically, how many patients will show you they have problem like that? Usually they will have problem like this. When I'm typing, when I'm doing my housework, when I'm holding something, then I lost power and I have numbness and things go on. So can you squeeze like that? So you can see that when Robin is holding the fist, the median nerve is very well. What about flex the elbow, flex the wrist, and then try to hold the fist? Still all right. Release, relax, and then hold that again. 加拳头，好，放松，好，再加拳头，再放松。Yeah. So when you keep doing it, the median nerve seems each time can escape from being squeezed by the flexor tendons, right? It's still fine. Well, let's take a look at if we have the Robin doing this. Okay, this time, please do that. Relax. Hold the fist. Oh, now you have the flexor pollicis longus and squeezing the median nerve between the flexor pollicis longus. This is the nerve, and that's the flexor digitorum tendons, probably superficialis, and this is the flexor pollicis longus. And then relax. And then when you relax, the median nerve is still between that. Okay, squeeze again. Oh, this time it's coming in now. So, do you have numbness now? Not yet. Okay, probably when you squeeze that for 100 times, you're going to develop numbness because you're prone to this carpal tunnel syndrome because each time when you're doing this, you are squeezing your median nerve and between the flexor pollicis longus and now you escaped. Now you come in. Okay, but when you extend the wrist a little bit, and this time squeeze again, and relax, squeeze, and relax, squeeze, and relax, and squeeze, and relax, and squeeze, and relax. It will not be squeezed. See that? So now your median nerve is safe. So if you're holding something like this, and then you do this holding the fist, your median nerve is going to be squeezed by the flexor pollicis longus and flexor digitorum tendons. So that is not good. So this time let's do that again, and then flex the wrist, squeeze again, and relax, and squeeze again. This time it's okay. Oh, relax again. Oh, now it's squeeze again. Then your median nerve does not like. Relax. And squeeze again. The median nerve cannot escape from being squeezed. Oh, still having some trouble. So if you keep doing it, I believe, 1 minute or 2 minutes later, you're going to complain numbness. Starting to feel any discomfort. You feel tired with your fingers or your thumb? Your thumb. Yes, your thumb, because that's your thinner branch or the recurrent branch of your median nerve, which is right next to your flexor pollicis longus, which is being squeezed by doing this. Okay, I think that's enough for a short demonstration how you can utilize this machine and then to do a dynamic ultrasound to make a diagnosis of musculoskeletal problems or neuromuscular problems. So if Robin is presenting with like a thinner muscle weakness, and at the same time when he's doing this squeeze, and then I'm going to ask the next question is whether you are squeezing, holding the fist, or having some repetitive movement, holding something, and with elbow with the wrist flexed or extended. If the wrist is flexed, and then I apply that, or just basically ask your patient when they are presenting with neuromuscular problems, ask your patient to reproduce the symptoms, and then you put the transducer down, and then you can scan that posture or scan that movement to see what pathologies or neuromuscular pathologies you can see underneath your transducer. So that's the basic principle of musculoskeletal ultrasound and dynamic ultrasound. Thank you very much for your attention.